Hi, this is Brian Ormers recording a lecture for medical surgical nursing on heart failure. So with this, we're going to compare and contrast left and right-sided heart failure. We're going to look at different stages of heart failure. We'll talk about patients with suspected or actual heart failure for some diagnostics. We'll look at nursing diagnosis for heart failure, including impaired gas exchange, decreased cardiac output, fatigue, and risk for pulmonary edema. We're also going to look at nursing interventions for patients who have heart failure. We're going to look at special care about the older adult with heart failure, and we're going to be doing some personal actions to maintain health and prevention of worsening heart failure. So heart failure is more common in people greater than 65 years of age, and it's very common for hospitalizations, unfortunately. It is a major cause of disability and death, especially after MI. So some of the risk factors for this are coronary artery disease, hypertension, diabetes mellitus, metabolic syndrome, obesity, smoking, and high sodium intake. So the type would be a left-sided or ventricular failure. Most starts as a left-sided failure, and so what you're seeing is that systolic heart failure or diastolic heart failure, but left side is your most common. You can get some right side, and we're going to talk about that here in a little bit, or you could get high output. So subjective, what are they going to think about this? They might have a medical history of hypertension, MI, rheumatic heart disease, or valvular disorder leading into this heart failure. They might have activity intolerance, breathing pattern changes, or sleeping pattern changes. They might have some urinary elimination and fluid volume status changes. With heart failure, oftentimes they've got fluid volume overload. With left-sided symptoms, they might have symptoms related to impaired tissue perfusion. So they're tired, they're weak, they've got dyspnea, orthopnea, cough. If this ever goes to pink frothy sputum, that's an emergency. That's pulmonary hypertension, and that's very bad. For right side, you're going to see out at the extremities of their body, so edema, their shoes might not fit, their socks are tight, their rings won't fit, they've got increased weight gain. Stokes sign, which is can't button their top collar of a dress shirt. They might have liver engorgement with this one, and of course with all of these, if you have nausea, vomiting, anorexia, and ascites. So with left-sided heart failure, some of the signs and symptoms you might see with that: weakness, fatigue, dizziness, acute confusion, pulmonary congestion, breathlessness, oliguria, an S3, crackles, wheezing, weight gain, and murmurs. So what do we do with that right-sided heart failure? So some of the things we're looking at this, we're going to see distended neck veins, increased abdominal girth, dependent edema. So once again, that right-sided heart failure is going to be a lot of your extremities and out towards your body. With the left-sided heart failure, it's going to be more of your respirations, because it's backlogging into your lungs. So with this one, we got different stages. So patients are at high risk for developing heart failure. That's class 1. And then patients with cardiac structural anomalies are high risk for developing this. Patients with current or prior symptoms of heart failure is class 2. And then patients with refractory end-stage heart failure. So you can kind of see that it's going up in value. So 1 is like low risk, and of course you got 4, which is high risk. So on your laboratory assessment, you might do a CBC, CMP, a BMP to assess for electrolyte status. You might check your BRN and creatinine to look for your kidneys and see if they are excreting enough fluids. You might look at H&H to depend if they've got any anemia present, which can be a sign of kidney disease. Might check the BMPs to look for acute heart failure. And then your analysis for SPECT CRAVs related to your kidney problems related to heart failure or hypertension. And then ABGs looking for things like hypoxemia, acid-base analysis. Imaging, chest x-ray, looking for cardiomegaly or pleural effusions from backing up of that fluids. You're going to look at an EKG to look at dysrhythmias and hypertrophy, as well as maybe even ischemia or injury to the heart. On an echo, you're going to look at the amount of fluid that's in there and your ejection fractures and stuff like that, looking for heart failure, looking for any valvular changes, effusions, chamber enlargements, or any hypertrophy. Other diagnostics, you might do some hemodynamic monitoring. This is more of a high acuity thing when you're floating your pulmonary wedge pressures versus med surg, but it is an option, I suppose. So with some of the nursing diagnosis, so you've got impaired gas exchange related to ventilation perfusion imbalance. You might hear this called VQ mismatch. V made sense to me for ventilation. I don't choose Q for perfusion, but that's what it is. So if you ever hear a VQ imbalance or mismatch, that's this. As a goal, optimal breathing is what we're trying to shoot for with increased gas exchange. So what can we do with that? Well, we can assist with their ventilations, maintain SATs of over 92%. This can be positional with how they're sitting. This could be with supplemental instruction or oxygen. This could be with, I suppose, even ventilation and those kind of situations. Could be some of the medications that we use to try and open up the airways. And then, of course, we're going to monitor respiratory rate, rhythm, quantity, and those lung sounds to monitor crackles and other signs and symptoms of fluid overload. As we look at decreased cardiac output, of course, we're going to try and improve heart rate and stroke volume. So your cardiac output, once again, heart rate times stroke volume. So what can we do with this? So reduce afterload, so decrease the pressure afterwards with your ACE inhibitors and your ARBs. We can also consider some of the side effects, therapeutic effects, and nursing implications of these medications. And then other things we can do too would be watch the sodium, watch the water, and so put them on a restricted diet. Diuretics, trying to get rid of some of the sodium in the water, is also commonplace with this. And looking at other decreased cardiac output, other interventions we can do too would be trying to enhance the squeeze or the enhanced contractility. So DIG is one of those drugs that we might do, but there are some nasty side effects of that, and we want to make sure that potassium levels are high enough before we give DIG. Can give beta blockers or beta adrenergic agonists, but realize that any med that you give, it does have side effects with it, so we want to monitor to make sure it's number one, effective, and number two, to make sure that the side effects are not significant. So as a challenge, guess what? You're giving somebody some Lasix, and valsartan goes in, sees a potassium level of 6.2 was the nurse's best action. So, I mean, you could go airway, breathing, circulation with this one. I'd maybe recheck the potassium level. I would not expect this one to be super high with them being on Lasix, but you could do that. And then you can look at serum creatinine and see how effective their kidneys are. So, I mean, this is one test, but I wouldn't expect it to be high with Lasix on board. So, with this, I would not give potassium as an IV infusion because that's just going to make this potassium level higher. 3.5 to 4.5 is kind of your general range, so I would retest the potassium. Alright, older adults taking DIG and hydrochlorothiazide for chronic heart failure admitted to the emergency department with atypical pulse of 48. Family member states the patient reported blurry vision and loss of appetite for 2 weeks. So what do you want to do first? So with this one, what I am kind of thinking about, digoxin's got a nasty side effect of having halos and different stuff like that around bright lights. And so I'm kind of thinking that this might be a DIG toxicity type of situation, especially as your apical pulse is less than 60. And so to me, that's pointing towards DIG toxicity. So calling ER physician, maybe not. It sounds like they're fairly stable, just blurred vision and loss of appetite. So I would maybe, call the provider and get an order for serum DIG. All right, other things we can do. So we talked about cardiac output management. So we could take it over. We could put a pacer in. So we could either pace the atrium or the ventricle or both. And so it just depends on what that patient needs. So that would be one way to try and increase contractility, trying to increase cardiac output. So biventricular pacing is what I was talking about with atrium and ventricle. Other things you can do too would be surgery, reconstruct that left ventricle if that's part of the issue. You can kind of, I forgot the name of it, it's not necessarily debriding, but you're kind of scraping the extra muscle out of here and taking some of that extra tissue out, hoping to get better contractility. If they have hypoxia, so we can try to increase their life while they're doing their ADLs by having them rest for conservation, planning group things together to minimize activity intolerance, work on outpatient therapy, try and build some of their stamina, and of course oxygen therapy with this. Nasal cannula probably being the most common. Risk for pulmonary edema, so hopefully they don't develop the pulmonary edema. If they do, things that we're looking for would be crackles, dyspnea at rest, confusion, anxiety, and tachycardia. Things that we want to do is give some oxygen for this, reposition into a high Fowler's, give some diuretics, trying to pull that extra fluid off, and then maybe even some morphine to decrease discomfort, but also to have that wonderful side effect of opening up the vasculature. So self-care, using the MODS plan, so medication, activity, weight, diet, symptoms. So if they're having a lot of these, they should let their provider know. So that concludes this quick overview of heart failure. Be able to tell and distinguish between right-sided and left-sided heart failure. That's going to be a major component for your exam. So, all right, any questions? Feel free to contact me.